Hi there, Dr. Safir. So,
Hi, Dr.
so good
Satterwhite.
afternoon, good evening, good morning. I guess depending on where people happen to be located, would definitely be a pleasure and an honor if there were people all over the world who are watching this. But once again, thank you for taking the time to hang out with us for the next half hour. This is an Instagram Live with myself, Dr. Satterwhite, Dr. Michael Safir. We're both part of Align Surgical. And today's title is Traditional or Robotic Vaginoplasty, Finding the Right Fit for You. And so I just wanted to start off with introductions. Once again, my name is Dr. Satterwhite. I'm the founder of Aligned Surgical Associates. So we're a private practice based in California. So we have an office in San Francisco and an office also in Los Angeles. And we serve exclusively the transgender, the gender diverse, and the gender creative patient population. So we take care of our patients from head to toe. So we're here for you to serve all of your needs. And once again, my background is my training was at Stanford in plastic surgery. I had a year of craniofacial fellowship training as well. And we have 6 surgeons currently in our practice. So super excited. And it's an absolute pleasure and honor to have Dr. Michael Safir as a member of my team. And his background is astounding. I'll have him talk more about himself.
Sure. So yeah, my name is Michael Safir. I'm a reconstructive urologist with Align, and I have been performing surgery for the transgender, non-binary, gender diverse patient population for about 6 years. And my specialization, I do only bottom surgery. And my background is I trained in reconstructive urology at UCLA and UCSF. Like I said, have been performing only bottom surgery for the last 6 years. So yeah, I'm really excited to see what feedback and comments we get. What we've done is we've disabled the comment function just to stay on point. That's sort of worked out for us really well in the past, but feel free to ask questions using the question function, and we'll leave some time at the end to go through your questions.
Yeah, perfect. And you're much too humble, Dr. Safir, saying that you just perform bottom surgery, right? Because that operation in and of itself encompasses so many steps. It's like 10 operations all in one. So you've got an amazing background, a very unique, set of skills that very few people in this country and very few people in this world have. So both vaginoplasty as well as phalloplasty. So you've had years and years and years of training upon training upon training to get where you are. So much too humble. But anyway, but yeah, once again, so as Dr. Safir was saying, just submit any questions you happen to have. But I just wanted to start off with just the basics. What is a vaginoplasty? I think it's important for all of us and all folks to understand what that is. And so vaginoplasty is, one of many, different types of gender affirming procedures that we do. And it's a procedure that's requested by trans women, gender diverse individuals, and what this operation entails is basically using current genitalia. Sorry, well, I mean, in one aspect, you can use your current genitalia, but in the more traditional sense, it's using the genitalia that you currently have. So phallus, scrotum, to produce and create a vagina. So creating all the external components, so the vulva, the clitoris, the labia minora, the labia majora, and then using tissue to create the vaginal canal itself. So most surgeons, a lot of surgeons now are doing what's called a penile inversion vaginoplasty, where they take the tissue that you have and invert it. So turn that inside out to create the vaginal canal, and then additional skin grafts can be needed if that's the case. And once again, this is a vaginoplasty can be one of the, for some patients, this can be the initial operation that they start off with. For other patients, it might be later down the line. They might start off with facial surgery, a breast surgery, and then move on to a vaginoplasty. But was there anything else that you wanted to add regarding vaginoplasty, Dr. Safir?
No, just to say, years ago, vaginoplasty meant one thing, and say phalloplasty meant one thing, and What we've tried to do is to customize or tailor our operations based upon what a patient's surgical goals are. And so, just when you're telling your surgeon what you want, just explain what your goals are and don't feel that you can't make your individual desires known. It's important to us and that we give you the operation that's right for you.
I think that's so important, like understanding for us as surgeons, it's important for us to understand and be on the same page with you in terms of what your goals and wishes are, because we never, want to be the ones who are telling you what is the right thing for you by any means. And I think that, it's important to, with that in mind, I mean, that's why it's nice to know that we have the peritoneal pull-through vaginoplasty and other different types of operations that are available depending on what your goals and wishes are, depending on what your tolerance is for, certain risks or complications. And this kind of goes in line because we do have some questions here. So Glenn, who I know well, Glenn, welcome. So Glenn does a wonderful job taking care of her patients pre and post-operatively, so scar management, lymphatic treatment. So thank you so much for all the care that you provide our patients. But Glenn is asking a really insightful question. When do you recommend electrolysis when someone is planning on vaginoplasty? So I think this is a perfect segue into, who would be a good candidate for the peritoneal pull-through and versus the traditional penile inversion vaginoplasty. So if you have a patient who just cannot move forward with electrolysis, for example, where they, have had a history of sexual trauma, which is very unfortunate. They have a history of post-traumatic PTSD, or they may not have access to hair removal and still have, and therefore the scrotum and the scrotal tissue is not going to be accessible, then a peritoneal pull-through vaginoplasty may be potentially a good option for that patient, right? Because the peritoneal tissue doesn't have hair on it. You don't have to do hair removal beforehand. But so for someone who is going to move forward with the peritoneal, for any type of vaginoplasty in general, just getting back to your question, Glenn, you want to start the hair removal process as soon as possible. Because once again, hair removal is permanent, right? So once you have it done, it's done, and you never have to worry about it again. So if you know that it's going to be part of your journey, then move forward with that. But anyway, that's one, you know, aspect or one reason why someone may pursue peritoneal pull through versus a penile inversion vaginoplasty. But there are a whole host of other reasons why the penile inversion versus the peritoneal pull through might be advantageous to you. But Dr. Safir, did you want to comment on the hair removal part of it? And then also maybe some aspects of, who may be a good candidate for robotic versus
Yeah.
traditional.
Well, whenever there's a choice in surgery, we know that no operation is perfect for every patient, and that's true for all aspects of reconstructive surgery. Um, I think the conversation that starts with what you're looking for is really important in certain aspects, like you said, where whether or not patients are able to do electrolysis or laser hair removal, it's really important for us to know. I think that the overwhelming majority of patients who have not had bottom surgery done and are looking for a sizable canal and external anatomy that looks right for them, I think as it is now, the majority of patients are pretty well served with penile inversion vaginoplasty. That said, I think that it's good to visit programs who actively perform both types of operations because if all we're doing is one operation, right, and there are no alternatives, then it's going to seem like that's the right operation for everyone. So I think starting talking about what you're looking for and speaking with your surgeon about what are the advantages of either. But for a first-time patient, I don't know, Thomas, what do you think about patient who comes in and says, I want to have good depth. Everyone's talking about robotic surgery. What should I do?
Yeah, that's a
You know?
very good point, right? And I think it's as you were stating that it's important that for you as a patient, you should be as informed as possible and really know about each of the operations because you might have friends or family members who've gotten a certain type of operation and they did super well, and then you're like, oh my gosh, I want that same operation. Right, but you really have to have a just a full understanding of all of the different options that are out there. And as you were saying, Dr. Safer, the penile inversion vaginoplasty is still the number one operation that we like to do for patients. So if you have an adequate amount of genital tissue, you've done hair removal, I think the penile inversion vaginoplasty, where you use your current tissue, the penile shaft skin, and then also the scrotal skin, that's going to be a good way to go to get good depth, and patients do quite well. I would, my thoughts have always been, and our thoughts in our practice have been that the robotic peritoneal vaginoplasty or the pull-through vaginoplasty, and we can talk more about the technicalities of that one, but once again, that's using lining from the inside of the abdomen to create the vaginal canal, which has become more popular. That I oftentimes feel would be best for patients who have had a prior penile inversion vaginoplasty, and that's failed in some way where it's developed what's called stenosis or closure, which can happen if dilation hasn't gone well or other complications. Then you can use the robotic peritoneal pull-through vaginoplasty as a way of salvaging or creating reconstruction of the vagina. And then if that fails, then you can move on to like a colon procedure. But that doesn't mean you always have to necessarily follow that particular pathway, because there's some patients who state, lubrication is important, self-lubrication is important for me. So then they would be a good candidate for the colon operation, because the colon does produce natural lubrication. So that's oftentimes a misconception that folks think that the peritoneal pull-through vaginoplasty creates lubrication. Anecdotally, some people state that's the case, but in reality, the consensus is that that is not the case. It's really only the colon procedure. But once again, I think it's important for patients, as you said, Dr. Safer, to speak with surgeons who offer all of these. And currently in our practice, we do offer the penile inversion, and now we're fortunate to be able to offer the peritoneal pull-through vaginoplasty. We can tell you about all the different, risks and benefits of all of these, and make sure that they line up with your particular goals and wishes. And that kind of goes with, I think there's another question here that, when someone's stating they had bilateral hernia surgery as a child, and what is recommended for someone who has had previous abdominal surgery? Very good question. So once again, that goes in line with, whether or not you would then be a good candidate for a peritoneal pull-through vaginoplasty. Because if you've had, significant abdominal surgery, like inside your abdomen, there might be a lot of scar tissue, and you may not be a good candidate for having the robotic peritoneal pull-through vaginoplasty. Right. So it's a very good point. So just letting us know, your surgeons,
Yeah.
your doctors know what the medical and surgical history is. So that is also an important component. Dr. Safer,
Yeah, what I was
thoughts?
going to say about hernia surgery in particular is a lot of surgeons, when they do laparoscopic hernia repairs, will use mesh. And that mesh goes in an area that may make it difficult to use peritoneum during the surgery. And so the specifics of what you know about your surgery. The other thing that I think is important to know is I would say that it's almost like 90% of the operation, penile inversion vaginoplasty versus robotic peritoneal surgery, it's the same. All the work that we do on the outside and developing the opening and starting the reconstruction of the vagina that's closest to the opening, that is really it's the same. And so these operations, while they have important differences, they share more in common than they differ. And so, I was talking with someone in Los Angeles about surgery, and they had said, the doctors who offer the penile inversion vaginoplasty, that somehow we're offering an operation that's dated or that is from a different era. But really, like you were saying, it's the most common operation performed now. To have the versatility to offer both operations, especially in complex or redo operations, and for the surgeon to have the freedom to be able to decide between operations so that they're not getting pigeonholed into doing an operation that may be not right for the individual patient.
Yeah, that is so true, right? It has to be a two-way discussion between the surgeon and then also also the patient, or even a multi-person discussion with like the surgeon and the primary care doctor and and the family members. But then, just to, really, so maybe I'll ask you this, Dr. Safer. So then who is a good candidate for robotic vaginoplasty? Who would be a good candidate for the peritoneal pull-through robotic vaginoplasty as an initial operation?
Yeah, I think in some cases, patients who've been on puberty blockers and
Mm.
haven't developed anatomy that would be sufficient to create even a good portion of the canal may be a good option. That may be a good option. Um, Patients who've, like we were talking about before, say you've had a penile inversion vaginoplasty, you've lost some of your canal. I think patients like that we can salvage some of the canal and then add to it with the peritoneum. I think that so failed or previous penile inversion vaginoplasty that's resulted in some loss of depth. And there are some patients, it's not necessarily like the initial operation went wrong. Some patients can't dilate or stop, or there's something that interrupts an ongoing process which is necessary for maintaining their canal. Something happens during the recovery, and they need something else done. I think if you also a patient who says, "Look, I want to have as much depth as possible," someone who says that, and I only want an operation that's going to give me as much depth as possible. A patient like that might be best served with peritoneal surgery, although we'd certainly have a conversation and say that I think penile inversion vaginoplasty could likely offer them what they want.
Totally.
Um, yeah.
And so then, Dr. Safer, so then if you had a patient who did have adequate genital tissue, right? They hadn't been on blockers, and and you tell them that, hey, I still think you would be a good candidate for the penile inversion vaginoplasty, but I really, 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 really want the peritoneal pull-through vaginoplasty. What would you tell them?
Yeah. What I've been talking with patients about is to really explore their path to surgery. Sometimes it's as simple as my friend had a peritoneal operation and it went great, and that's what I want. And the power and the value of having someone you care about doing well with surgery, that's not to be discounted. It's really important. But I would just explain to the patient, like we do for all of our operations. These are complicated operations. We try not to make a big deal out of them, but they're really complicated operations, a lot of steps, some of them perilous that may result in a complication or a problem with healing, and explain to them things like intra-abdominal surgery using a robot. There can be injury to the bowel, injury to the bladder, bleeding, injury to major blood vessels. Those things are relatively uncommon, but I think that with a lot of the press that peritoneal surgery, robotic peritoneal surgery is getting, I think it doesn't talk about some of the complications that would be extraordinarily rare to encounter with a simple or a simpler penile inversion vaginoplasty. What do you think, Thomas? Like, how do you talk with patients? Because obviously they're coming in, someone they know had surgery. Maybe you did their friend's surgery, or they had their friend lives across the country and they had robotic surgery. How do you counsel them?
No, it would be the same thing that you did. So once again, or that you would do, like addressing their goals and wishes, letting them know that, once again, if you pursue the peritoneal pull-through vaginoplasty, and that vagina closes off for whatever reason, we can't go back and do another, you cannot do another peritoneal pull-through vaginoplasty. At that point, you'd have to move on to a colon, right? And
Yeah.
so then that kind of, I suppose, burns
Yeah.
that bridge. But
Yeah.
once again, that goes along with, with the, why someone who has adequate genital tissue would move forward with the robotic peritoneal pull-through. And you brought up one of the advantages, the potential advantages, because there are some studies that do show that with the robotic procedure, you can actually get a little bit more depth. Not a huge amount, maybe, 1 or 2 centimeters or so. And there's still more research that's being done, right? But that seems to really be, as far as I can tell, the biggest advantage is just a little bit more depth. Because you still have to, you don't generate any lube or lubrication, and you still have to dilate. This is a question that
Yeah.
Glenn brought up, was vaginal dilation or pelvic therapy between the two different types of operations. You still have to dilate. It's not a self-sustaining vagina. Like, you still have to continue doing lifelong dilation.
Yeah, agreed. One thing I'd say also is, as surgeons, we're concerned about everything and worried really about nothing, or we really try that. And it should be said that really we love these operations and we think they're awesome and they really make a difference for our patients. And we have incredible optimism for the future with the addition of other operations. And it should also be said that, like, it's not just the peritoneal addition to surgery is not the only advance that's been made in the last 4 or 5 years. There are really important changes in the way that penile and virgin vaginoplasty has been done that have really catapulted it to really keeping itself as the number one operation. But even though we talk about complications and differences and concerns, really what we have are really awesome operations and awesome relationships that we make with our patients that give us the opportunity to step into their lives and make important changes. And so while we talk about the difference, what do I do, this one, that one, really, there's really an opportunity to discuss it, and the opportunity is one of incredible optimism for the future.
No, you're so right. I think that the best way for any patient to come in is, once again, going to a center like ours that offers multiple options, and then just let us know what your goals and wishes are, and then we can break down, what each of these operations entails in terms of what the preoperative preparation is, what happens during the operation, what the potential risk can be, what the postoperative recovery and regimen is, and then you can, decide amongst, all the things that we've provided you, what would be the best route. That's the best way to go, because yeah, you hear a lot, you see a lot on the internet, a lot on social media, and this applies to everything, not just vaginoplasties. So it's really hard to be able to know what's going on. So that's why spending time, talking with us is going to help tremendously. And then, this kind of goes along with, a question that someone did ask here, and it was about age. And she was saying, this is from Jay. She was saying, does age complicate or present other concerns? So on top of all the other concerns we talked about, but does age complicate or present other concerns when exploring vaginoplasty? 50-year-old here. 50 is young. Okay, no way. I mean, the oldest patient I've operated on, actually my birthday's coming up here, but the oldest patient I operated on was 78, and she did well. So it's more than just, if you're 50 and you're healthy, you're going to do well. I mean, there's certainly, and Dr. Safir could also say the same thing, that we have patients who were in their 20s but have a lot of medical issues. They have uncontrolled diabetes and they're still smoking, right? Or they're using certain medications that can predispose them to bleeding. So those patients we worry about, but a 50-year-old who's healthy, no. But that is a very good question, though, Jay, because we once again want to take into account all of these different factors, right? Age, or medical history, or surgical history, as we think about together what's going to be the right operation for you. You know. So, and someone did ask a very, I mean, this is a pertinent question, but someone said, just kind of like breaking it down to make it simple, um, what is the difference between the two? So, Dr. Safir, just like in 30 seconds, can you
Yeah.
talk about that? Because I just realized we've been getting into a lot of the technical aspects, but did we really break down the
So,
difference between?
so what I would say the difference is how the top of the vaginal canal is performed. And I've scrubbed in on a lot of robotic surgery, and that's how I sort of how I made how I began to understand the operation. The part of the vagina at the opening is identical.
Mm,
Above where that part is, we put some of the scrotal skin that further adds depth to the canal. And the difference is sort of like the snow peak on the top of Mount Fuji, right? You have this really tall mountain, and on top of that, you've capped it with some additional real estate. You have a little bit more width and length at the top, and you may have some additional anchoring abilities because the peritoneum is anchored in position that helps keep the vagina up. But that's the best way. I mean, you can ignore the Mount Fuji thing that was a little bit
no,
obscure,
it's in my mind. It's never
but
going away. It's
it's
there.
the top. It's the top of the canal.
Okay.
So.
So with that being said then, and thank you for breaking that down. So then what is, the benefits? I know we touched upon this, but like a bullet point, like what are the benefits of the robotic vaginoplasty?
Um, I would say the benefits are that you can get a little bit of additional depth. It may be an option if your genitalia doesn't lend itself to creating a decent canal. Um, I think that patient preference is important, and to get the operation you want and need, and if it's appropriate, we'll give it to you. I think taking advantage of new technology is always exciting, and as surgeons, we're looking to expand our experience. Um, but I think they're very similar operations, and the best operation is the best operation in that surgeon's hands, right? And
Agree.
that's what I'd say.
Yeah, I think there are more similarities than differences, and it goes back because I think one of the misconceptions is lubrication, and that's just not going to be the case. And just to go back, and because I know there had been another question that was submitted by the audience, was about, do you need hair removal for robotic vaginoplasty? In general, you still should, because there are going to be components of the genitalia that are going to be used in the canal. So, but once again, if you can't do it, then we won't be able to use that, the genital tissue, and we'll probably have to use more of the peritoneal tissue. So just wanted to just make sure that I addressed those questions to whomever submitted that beforehand.
The one thing I
But I
thought about
think,
really quick, zero depth and minimal depth
mm,
vaginoplasty or vulvoplasty, you don't need robotic surgery. It doesn't have a role. You wouldn't use it. So you don't have to make that decision.
that's a very good point, and that goes to one's particular goals and wishes. If hair removal is something that you have do not want to move forward with, and you have no desire for a vaginal canal, as you said, then doing the minimal depth or zero depth is certainly a wonderful way to go. And once again, it's just important to talk with your surgeon. There are a variety of genital affirming procedures that can be performed, and we will just, once again, just kind of help you and guide you along in that process. So we're coming to the half hour mark. It goes by so quickly. Time flies when you're having fun, doesn't it? But I just wanted to thank everyone for being here. I know that you have a choice of doing so many other things today, and you have made the choice to be with myself and with Dr. Safir. So it's a true pleasure and a true honor. So if you want to know more about vaginoplasty, about robotic peritoneal pull-through vaginoplasty, which we do now offer, then go to our website, www.alignsurgical.com. We are always here. Reach out anytime. So once again, I'm based in San Francisco. Our beloved Dr. Safir is in Los Angeles. And so we are here to serve all your needs.
Thank you.
Okay, thank you. Take care, everyone. Bye bye.